because you know I do that sometimes. Okay. Yeah, see now there's a big square in front of it again, like right in the middle. Good evening, everyone. We're just getting people admitted into the Zoom room, and then we will be getting started in just a little bit. All right, everyone, I'm going to go ahead and get started with our introduction as people are still joining. Welcome to CVSA's November virtual presentation, Meeting the Challenge of Emergency Care in CVS. Before I introduce our speaker, I want to introduce myself. My name is Debbie Conklin. My involvement with CVSA started with organizing the Run for the Bucket in Wisconsin shortly after my son's CVS diagnosis in 2005. In 2007, I joined the CVSA Board of Directors, and in 2016, I became the program director. So if you've contacted me since 2016, or if you've contacted the office since 2016, you've talked to me. Just a few housekeeping things. For the duration of the presentation, you will be muted just because of background noises distracting to both the speaker and those attending. If you're not muted, we will ask you to mute. Also, please do not use your own recording device during this presentation. We are recording it for later viewing on our YouTube channel. If you're having trouble with your audio, you may consider using your phone to call in instead of using your computer speaker. We have about 100 people on this meeting registered for this meeting tonight. Unfortunately, that means we may not have enough time for everyone's questions, but please put your questions in the chat box at any time, and then we'll ask them all to Dr. Eisenmann at the end. And now for the main attraction. We would like to welcome Dr. Robert Eisenmann as this month's presenter. Dr. Robert Eisenmann is Professor of Pediatrics at McMaster University in Hamilton, Ontario, Canada. In the past, he has held many roles at McMaster Children's Hospital, including Chief of Pediatric GI and Nutrition, Associate Director of the Emergency Department, and Director of the Ambulatory Pediatrics. Dr. Issenman has played a key role on the CVSA Medical Advisory Committee as the only emergency room physician. He has been part of both the adult and pediatric treatment guidelines, as well as CVSA's main Canadian connection. Dr. Issenman has published studies on autonomic function and cyclic vomiting syndrome. And Dr. Issenman is fondly described by his patients as a compassionate doctor who is willing to listen and help get the right answers for the patient. So now I would like to welcome Dr. Issenman, and we look forward to hearing from him today.
Good, thanks, Debbie. And there may be a little disruption while I try to convert my screen. Let's hope that we get to it here. And there's my PowerPoint. Full screen, and we want to share screen. Okay, there. And anybody see a screen yet?
I can see it.
You can see it? Okay, thank you for that. And we're trying to get it to the full screen here. There we go. Okay, now what you should see is the full screen. Somebody give me a thumbs up if that's what you're seeing. Okay, good. Well, thank you everyone for showing up. I understand that we have folks from all over the US, and I don't know if we got folks from elsewhere. And the topic, as you see, is cyclic vomiting syndrome in the emergency department. Now, before we start, I want to share a caution about this, which is that Debbie asked me to do this talk 4 to 6 weeks ago. And there's been a few things that have happened in the meantime, one of which is this explosion of COVID infections in North America. And of course, in certain areas of the country, the hospitals are pretty stressed out and overrun. And as much of my talk has to do with how to deal with a hospital and learning how to, who to talk to in the hospital, it may be hard to get their attention for cyclic vomiting when they're trying to deal with the stresses that we have all heard about. But even if you can't sort of put this action plan into effect now, it'd still be good next spring. So we're going to start off with a story, and I'm going to move this little panel out of my field of vision. There we go. So Megan has a familiar story of having had cyclic vomiting since she was 13. She's one of those people in whom it's accompanied by migraine headache. And she gets episodes about 4 to 5 times a year. And when she gets sick, if she can't catch them in time, they last for 2 or 3 days and are exceedingly disruptive to school and work. She tries to take ondansetron or Zofran, same name, at home. But if she doesn't catch it in the nick of time, then she's going to be sick for a while. She works with her family doctor, and over time, they have a treatment program that works very well for her. And he's written a letter outlining what works for Megan. And of course, at her next attack, Megan goes down to the emergency department where, of course, she waits about 3 hours in a noisy emergency department waiting room to be seen. She eventually sees a doctor who takes her story, does some blood work, and gives her the ondansetron, which didn't work at home. And then they watch her for another 3 hours. And eventually, even though she's not feeling that much better, she's sent home with a diagnosis of flu. And as she leaves, they give her the letter that her doctor sent. And it's pretty clear that no one even looked at it. And so typically, Megan stays sick for another couple of days and vows she's never going back to the emergency department again. So if you are a patient, this is kind of bewildering as to why this would happen. And if you're the outside doctor, it's bewildering as to if you've worked with the patient to figure out the best treatment for them, why wouldn't the emergency department want to use that treatment plan? And, when they asked me to run the emergency department for a few years, I was given a golden opportunity to try and come up with that answer. And what I was shocked about was, in fact, If you bring a set of instructions to the emergency department in the US, in adult hospitals, it will be looked at or used about half the time. And even in our own hospital, when I was running the emergency department and we did a retrospective review, I found out that the letter was only used about half the time. So why would that be? And in order to understand that, you have to kind of get to the other side of the gurney, as the expression goes, and maybe be inside the emergency department looking out instead of inside the emergency department looking in. And the first thing you have to recognize is that cyclic vomiting syndrome, which is an enormous burden for the members of this association, is actually pretty rarely seen amongst the thousands of patients that are seen in an emergency department. And the truth is that most of the patients that a doctor will see actually do have the flu. If you reduce it down to the patients who have headache, for which cyclic vomiting may be related, that's only about 3% of the patients in our emergency department. And of those, only 10% have cyclic vomiting. So what it means is that if you do the math, the average emergency physician will see no more than one patient with cyclic vomiting a month, and many will only see one or two a year. So they're pretty unfamiliar with it. And as I've said, they may have heard about it, but it's very much in the distance on the horizon compared to the things that they worry about. So the second thing that is very hard to wrap your head around, and it's taken me years to understand it, is that in most instances, doctors don't work for a hospital. They actually are contracted as individual practitioners, and they're held individually responsible for the care they provide. So what that means is that if you're running a hospital and you want something to happen, you negotiate with the nurses, because the nurses are employed by the hospital, and they will basically carry out hospital policy. But emergency physicians generally don't have that relationship. Number one. Number two is because they're individually responsible, even though patients will present with a letter from an outside doctor, if something goes wrong, the emergency physician's defense that somebody gave him a letter from a doctor he doesn't know, and he followed out the instructions, won't stand up for more than a couple of minutes. And accordingly, the docs are very reluctant to be put in a situation of using somebody else's instructions. The third point that I reiterated before, which all things considered, it's pretty rare. And while it's miserable for the patient, as you all know, generally it's not life-threatening. So in terms of getting the attention of the physician and asking them what they're worried about the patients who come in with heart attacks or overwhelming infection or bad trauma, because if they don't get it right, it's going to be a disaster. And again, the review by Dr. Venkatesan of all the hospital admissions in the United States showed that very few of the patients, very few patients actually get deathly ill. And then lastly, and all of you who've dealt with the emergency department deal with this issue of the feeling that you're being accused of drug seeking. And, why would they do that? And the answer is, in fact, with the opioid epidemic, patients regularly show up in the emergency department with a variety of complaints looking for some kind of opioid. And the emergency physicians are going to see several of these patients a day compared to the patient that they might see with cyclic vomiting syndrome every few months. So their mindset is preoccupied with not being taken advantage of, because they will be held accountable if a doctor in an emergency department gives a patient a prescription for narcotics and it's later found that the patient is going to multiple hospitals to get the narcotics, the doctor actually will get called up on the carpet and held to account. And then there's this thing, you can't tell me what to do. Now, as a pediatrician, we know about toddlers, and the toddler's favorite expression is, "You're not the boss of me." And truly, you know, there are a lot of people who never grow out of that. And particularly doctors, emergency doctors, don't like to be told what to do. I mean, when you crawl inside of that, well, why are they so difficult to work with? The answer is, if you sit in the emergency department, you're bombarded with people who show up in the emergency department with a letter or note from their doctors suggesting that they have an X-ray or a CAT scan or an MRI or whatever Dr. Google is recommending this week. And the doctors are not allowed in the first instance to just do whatever anybody tells them. And often the requests, or not often, but enough of the time, the requests are inappropriate or not indicated. And so emergency physicians really do have a reflex of, you can't tell me what to do. Not all emergency physicians, there are some that are very, very obliging, but enough that it accounts for the fact that 50% of the time, you know, the letter that you bring will not be followed. So how do you get around that business of you can't tell me what to do? And I've challenged some of my more difficult colleagues with this, is that, tell me about this. And they said, we're only going to do things if it comes from a trusted source. And I said, well, what do you consider a trusted source? And they say, well, best evidence from the medical literature, a published treatment guideline, like the ones that CVSA put out and publish in medical journals. A care plan. A care plan is a directive where the patient gets a specific series of treatments that has been vetted by the individual hospital, or advice from a trusted colleague. There's a famous expression in medicine called see one, do one, teach one. And doctors have learned the story of baking a chocolate cake, which is someone may give you the recipe for the chocolate cake that works, it's absolutely delicious. But you can bet that when you go to bake that chocolate cake, there's one little secret or one ingredient that they haven't told you about. And unless somebody's held your hand while you're baking that cake, your cake's not going to turn out the way everybody hoped it would. And similarly, physicians are very conservative, and they won't do something that just because it's written down in a guideline unless somebody's held their hand and remained with them by their side as they do something different. Lastly, in the last 10 years, we've recognized cannabinoid hyperemesis syndrome, which means, which we see usually in young people, mostly males, who show up in an emergency department with protracted vomiting. And if you take a history, what you learn is that they've been smoking weed on a regular basis. And the question is, well, why would they do that apart from the entertainment value? And the part of the explanation is that cannabis is hyped on the internet and in social media as being a treatment for nausea. If you stop 100 people on the street and say, does cannabis help nausea? Most people will say yes. And the reason for that is that there's a grain of truth in that, which is cannabis can, in some people, quench nausea and vomiting. The problem is there's a certain group of people where it changes their body chemistry and it actually produces protracted vomiting that looks a lot like CVS. And of course, the legalization of pot has put a spotlight on cannabis. Ironically, because it's interesting, more ER docs have heard about cannabinoid hyperemesis, then they've heard about CVS. And CHS still carries the stigma of drug abuse, even though it's medically sanctioned in many states. The idea of people taking a drug that once was illegal and of course is completely uncontrolled in terms of its power and synthesis raises questions. So that in this day and age, most teens and adults who show up with cyclic vomiting are going to be asked about their use of cannabis. So the question is, this would tend to make you a bit of a pessimist around, will things ever change? And I can tell you that ER doctors are willing to change. But first you have to get their attention. And this is a particular challenge in terms of emergency department physicians, because the reason they go into emergency medicine is because they've got a short attention span. And many of them have attention deficit disorder, number one. And number two is everybody in the world is trying to get their attention. So the heart attack people are trying to get their attention, and the stroke people are trying to get their attention. And the people who really get their attention are the people who come in with either life-threatening injuries or losing bright red blood from any one of a number of places. So trying to get their attention for something that is not perceived as life-threatening is a challenge. So how do you get an ER doctor's attention? And it requires calling on a higher authority. So there are many forms of higher authority. You can get the tablets from, well, not those kinds of tablets, but the tablets in this case come from national medical associations like Cyclic Vomiting Syndrome Association, or the American Gastroenterology Association, or the American Pediatric Academy, or North American Society for Pediatric Gastroenterology, and so on and so forth. So is there a model for this? Well, the higher authority, in this case, do create guidelines, patient care guidelines for common conditions. You can think of heart attack, strokes, blood clots, and migraine headache. And the reason that I've starred migraine headache is, in your discussions with the emergency department, you may not win the attention battle. You may not convince them that they ought to make cyclic vomiting syndrome their highest priority. But if they actually have a guideline for migraine headache, you may convince them to adapt the migraine headache guideline to your situation, because in many instances, the treatments are very similar. And also, you're not trying to educate somebody, they already know about these. So this is what we've done in our hospital, which is I sat down with the neurologist who was doing the migraine headache guideline and care plan and order set, and we made them mimic each other as much as possible. So there are guidelines which come from societies, and there are order sets. An order set is doctor's orders, which state, and we'll go through some of these. You look at the patient, take some blood, you start an IV, you give some medications, and all the doctor has to do is sign it, and those orders get enacted. And care plans are a little more of a nursing guideline of take the patient in, take their vital signs, put them in a quiet, dark room, and put the doctor's orders into motion. So just to point out that there are at least these three different categories of ways of getting predictable care. So how do you get the emergency department to adopt a treatment guideline, care plan, or order set? And this is the big take-home message. And I'll talk a little bit about this, which is we've talked about the fact that bringing in a letter from your doctor is not going to be reliable. It might work once or twice, but if you're trying to get it to work 95% of the time, evidence or experience would suggest that's not going to work. You might think, well, I'll talk the doctor into it, but I've just spent 10 or 15 minutes explaining why it's unlikely that you're going to be able to convince the doctor of what the best treatment for you is. But what you realize is, in fact, the emergency department management is responsible for this, and you're not going to be able to find the emergency department management at 11:30 or at night or 2:30 in the morning, because people who manage things are there during weekdays, and they work from usually 7:30 to 4:30. So you have to take this on when you're well. And that's the take-home message, which I'll probably underscore a couple of times. So how would you go about planning to take on, this is a monumental challenge. How would you do that? Well, let's say if you wanted to climb Mount Everest, how would you go about it? You wouldn't show up at Mount Everest on Tuesday afternoon with a pair of running shoes. If you're planning to climb Mount Everest, you would make a plan in advance, and you'd look at the route, and you'd find the easiest route. You would sit there and say, what are the biggest obstacles I'm going to have to overcome? You'd put together all the supplies. You would leave early because you would plan for things to go wrong. And, most of you know that things are going to go wrong more often than they're going to go right. So what does pre-planning look like? Well, first of all, you want a firm diagnosis, and that means finding a physician who knows something about this condition and maybe has some experience and has a bit of authority. And I have to say, I understand that most of the audience is an adult audience, that in pediatrics, it's really been the gastroenterologists who take the lead in this. But in adult medicine, I have to say it's the neurologists or a committed family doctor. And I'm happy to talk about why it's rare to get an adult gastroenterologist to be interested and knowledgeable about cyclic vomiting. Secondly, pick the best route. And we talked a little bit earlier about the influence of COVID, which is, if the hospitals are jam-packed, hospitals may not be the best place to go if you need intravenous support. So Dr. Venkatesan has told me for a number of years that what she does is she organizes that her patients can go into an infusion center outside of the hospital and get IV hydration and IV drugs with a set of orders that are set up in advance. Or alternately, some of our patients have the ability to get home care. And again, I know a lot of people are concerned about going into an emergency department waiting room and they don't want to pick up COVID. And so it may very well be worth exploring what the options are in your community. And certainly assembling the supplies. And by this, I mean being sure to have your medication, the right medication at home for both when you go in and when you get back from the hospital. So the business, what does pre-planning look like? Have your treatment condition written down on letterhead, if possible on official stationery. If you can get a wax stamp from your bank or anything that gives it the most authority, go for it. But what you really need to do, or you're going to have more success if this is linked to an official evidence-based treatment guidelines. And in adults, we have the ANMS adult CVS guideline. Bringing the guideline to the hospital is not going to help because, as I said, emergency doctors have a short attention span and they're not going to read anything that's more than a paragraph. And fourth, the pre-planning, and the message here is try to work with your hospital to get a care plan or an order set. And I would say here, the other thing we've learned through CVSA is actually you're going to have better luck with a small hospital than with a big hospital. In smaller hospitals, if you're going to be a frequent flyer, people actually get to know you, and it's easier to change routine. Whereas in a big hospital, they may have 30, 40 different doctors. Trying to get any kind of consistency is going to be a real challenge. And then lastly, this point about meeting separately with the emergency department chief and the clinical nurse manager. Now I'm going to talk a little bit about what that's about. I talk about it later on, but just to, sometimes it's worthwhile to tell people what you're going to tell them, tell it to them, and then tell them what you told them. And so I'm going to tell you what I'm going to tell you. And what I'm going to tell you is you're not going to have much luck meeting with the nurse, the clinical nurse manager, unless she knows that the chief of the department, in other words, the physician, agrees that what you're asking for is reasonable. So you should ordinarily meet with the emergency chief first, but don't count on them to actually be able to change anything that happens in the hospital, because that's their great frustration, is the doctors just don't actually listen to them either. But the clinical nurse manager is in a position to see that things happen on a consistent basis. So we said understanding the obstacles. We've talked about CVS being rare and trying to get people's attention. One of the things that makes the condition difficult is that while the symptoms are similar for everybody, the treatment is different. One size fits all does not work. And so you have to have your treatment plan tailored to your system, number one, called personalized medicine. And this is the tricky part. And this is, I'd spent years trying to figure this one out. You have to have a process that identifies you as having CVS. And in our experience, what we did was we issued patients with a card, and they went to the emergency department that I ran that said, you've got CVS, and people would throw the card away. And the receptionists didn't know what to do with the card because it wasn't part of hospital process. So then we developed a system called an alert system for any patient that had a rare condition, and they would bring the card, and the card said, look in your electronic medical record, please. And we could get some cooperation from the business clerks to do that. But then there's this process of linkage, which you've got your identification. I'm the patient who has this, has to be linked to the care plan. And emergency departments are chaotic places. So the care plan has to be someplace that it can be found for this relatively rare thing. And the best place is in the electronic medical record. So if you can work with your new partner, the clinical nurse manager in the emergency department, to get that care plan put in the electronic medical record, that'll solve 90% of your problems. And the last one, and this is really embarrassing, which is a lot of emergency physicians will not even look up the patient's previous history before they go see them, because what happens is they pick up the chart and they will see 20 to 30 patients in a 8 to 12 hour shift, and it says vomiting. And in their head, they've already decided that the person has the flu, and then they go in and they confirm. It's called confirmation bias, which is given that they've already decided, they've already got the treatment plan worked out in their head, and you're trying to get them to change their minds. So I talked to the emergency chief about this, and I got not much progress. And I talked to the clinical nurse manager, and I didn't get much help. And in my frustration, I was complaining to the admission clerk about this. And the admission clerk said, why don't you tell us? Why don't we put the care plan on the chart when we're still using paper charts? And what I realized is, there are 30 or 40 docs, there are 50 nurses, but there's only 4 or 5 registration clerks. And if you can and if the registration clerk puts the order set on the chart, then when the emergency doctor picks up the chart, they find this order set, and it doesn't play into this business of someone's telling me what to do. They look at it and say, oh, all I have to do is sign this. And that actually turned out to be the one thing that we accomplished that was more effective than anything else. So of course, it depends on, there's so many different variables, which emergency department. But I hope that this description at least explains some of the obstacles that you've been running into. Now, again, whether we're able to do anything about this during COVID is really anybody's guess. So this is the point that I wanted to make. Who are the crew in an emergency department? So the emergency department is run by a clinical nurse manager. The chief of the department is a doctor, and they're there to maintain quality of care, but they actually, people don't always listen to them. Emergency room physicians often work as independent contractors. And last, there's the patient relations department or patient experience department. Now, the patient relations department is usually there to deal with complaints, but that doesn't mean you have to wait till you have a complaint. If you phone up the patient relations department, well, let's say, I'm going to back up. If you have struck out getting in touch with the emergency chief and the emergency manager, the manager won't meet with you, it's within your rights to get in touch with the patient experience or patient relations department. Now, when I ran the emergency department, the one thing that would give me nightmares was the phone call from the patient experience or patient relations department. Because first of all, you didn't like to be exposed. And second of all, I mean, no one likes to, even if I did the right thing, you don't like that kind of spotlight. But mostly it was just a pain in the butt because it's this long process. There are forms to fill out, there are meetings to be held, and anything you could do to avoid having to meet with the patient relations, patient experience was a good idea. So to go in, if you're having trouble shaking up the hospital, to go in and say to the patient relations department, I don't have a complaint yet. What I want to do is I want to work with you to avoid having to meet with you around a complaint. And what that does is human relations work much, much better if you're coming from a good place, positive place, and you don't represent a threat, because the moment you look like a threat to the system, everybody goes into their defensive posture, and it makes it much, much harder to accomplish anything from once that tone is set. So what is that all about? So this is actually a relatively good-looking emergency department compared to some that I've worked in and many that I've seen. And the question is, why do they look like that? And there's an explanation. And that's called emergency room culture. And if you think about it, much like schools and street corners, emergency rooms are public facilities. So one of the reasons they look the way they do is they cannot refuse service to patients. Anybody, I think it's federal law in the US that anybody comes into an emergency department has to get care. And in any given shift, there's a woman, usually a woman, it can be a male actually, called the charge nurse. And she's a fearsome character. And the reason that she's called the charge nurse is her number one job is to maintain control of the emergency department. And the reason that these people, men or women, get kind of testy is if they are not in control, you get a mob mentality. And this goes down to little details, like if they pull somebody in who arrived after 2 or 3 other people, the next thing you have is 2 or 3 people charging at the charge nurse to complain that those other people got in first. And so much like teachers, my daughter's a teacher, And the first day of grade 1, she does something frightening to get the attention of the class, just to make it clear who's in charge. And similarly, the reason I give traffic cops a whistle is to make it clear who's the boss. And similarly, the charge nurse, because it's really true that if in a group of people, if someone isn't in charge, things are going to go downhill. So your support team has to start before you show up dealing with the charge nurse in the emergency department. And so it starts with a physician advocate. Now, when I talked to my friend, the difficult emergency doctor, and said, what would it take? He said, I will take direction from somebody that I trust. So there are people in your community who have a good reputation, who have relationships with the people in the emergency department. But most of the people, I dare say, in CVSA are not necessarily the experts. Mostly it takes a doc who is committed to patient care and is willing to go the extra mile. And the question really is, are they willing to have a discussion with the medical chief just to say, my patient has cyclic vomiting syndrome, and we would really like to work with the hospital to get some consistent care? Because the nurse manager is not going to do much unless the medical chief says that that's a good idea. And the medical chief's not going to do much unless he hears it from an authority. And lastly, like I said before, if you can't get any traction, then there's always patient experience or patient relations. So there's a plan for things to go wrong. So we talked about trying to identify an alternate care facility, such as home care and infusion clinic, or sometimes a smaller hospital. For cyclic vomiting syndrome, you may actually be better off going into your little local hospital or even a hospital in a suburb, which is smaller and less complicated and capable of kind of hearing what you have to say. If things go wrong, I'm sure I don't have to tell you folks, avoid getting labeled as a difficult patient. And I'm going to do a little sidebar here, which is some people manage to get the best care out of the healthcare system, and some people manage to get the worst care of the healthcare system. So if I'm on the ward, I can actually spot a room where the nurses are going in to look after the child and the family, and I can spot the room where people are going out of their way to avoid. And the ones where who get the best care are anticipation, sublimation, humor, and optimism. These are the 4 characteristics of dealing with called adaptive responses. Anticipation, the attitude of, I know we're going to work together, things are going to be okay. Sublimation, this may suck, but one day this is going to be better. Humor, the person with a vision problem says, I can see what the problem is, and that the humor disarms people. Anticipation, sublimation, humor, and altruism. Altruism is helping other people, and the patients who get the best treatment in hospitals are the ones who in fact are seen to be helping other folks. And guess who gets the worst treatment? Anger, it's a stage of grief. Anger, denial, bargaining, and then splitting and bargaining. So if people are angry, people who are told, refuse to kind of be at all cooperative. Splitting, you'll see this where people go and say, that you're a good doctor, but every doctor I've seen up till now has been a crank. Because the doctor knows that they're just next on the list. Anger and bargaining. And finally, bargaining is where people will take half the treatment. In other words, well, I will take the IV, but I won't take the Zofran. I will, and people get into this kind of adolescent negotiation. And, you can understand why, but in a way, those kinds of behaviors predict that you're not going to get the care that the person in the next bed might. So I know it's difficult, but be polite and try to avoid getting labeled as a difficult patient. Be persistent. What I mean by this is, if you have a bad experience, and you are going to have a bad experience, dedicate yourself to using that as the discussion point for your next meeting. This is a marathon, it's not a sprint. And what you want to do is you want to work towards reliable, effective treatment. This point about treating the ED folks as partners, and if you can make somebody your hero, they will move mountains for you. And that includes the doctors. And if you pick a doctor and decide you're going to be my hero and make them feel like a hero, they will often do what you can't do for yourself. And altruism, lastly, when you're working this through, if you end up with patient relations or the manager, there are many other conditions where people have a similar dilemma of having a rare condition. And if you work with them and say, look, this is not just for me, but maybe there's a bunch, why don't we work out something for all these people who come to the hospital frequently, but with rare conditions. So why wouldn't an emergency room manager agree to work with you? Well, they are committed to good care. Their chief value is seeing the place run smoothly. They like solutions that make their operations more efficient. They are held to account for minimizing length of stay. So if you go into an emergency department and you're held there for 18 hours or 24 hours, the hospital is actually penalized. And if you can work with the hospital to come up with a treatment that gets you in and out in 3 hours, everybody wins. And that sort of saves space, because the thing that emergency rooms dread is a patient that ties up a room where they might be able to see 3 patients an hour. So you actually have something that a bargaining chip when you go in for your conversation, in that these individual treatment plans will decrease length of stay. And what you find is, if you've got an arrangement worked out with the hospital or the infusion clinic or home care, that decreases the number of episodes significantly in and of itself. And we can talk a little bit about why that happens. So I've used the 45 minutes, and we want to leave time for discussion. So I'm not going to go through the rest of my slides. Just to say that when we've looked in the pediatric group of what works, the medications work between half to 3/4 of the time. And what that means to me is you've got to find the treatment that works for you if we're looking for 90 to 95%, and it's not going to be the same for every patient. And then these are the protocols for treatment in the emergency department. And the adult protocol, the only thing I'll draw your attention to is it does divide the patients up into different groups. So if it's predominantly vomiting, there's a certain set of treatments. If it's predominantly like migraine, either headache or abdominal pain, there's another approach. And for many patients, for understandable reasons, there's lots of anxiety, and treating that is helpful. And this is just the protocol that the ANMS came up with. I'm going to walk through it there. We don't need all that detail. And in the takeaway message, which I told you what I was going to tell you. I told you now I'm going to summarize it. Work with your doctor to develop an emergency care plan. You may find that taking an existing migraine pathway and just adapting it is the easiest way to get buy-in. Engage your emergency department manager, but have it endorsed by the chief of the emergency department. And then once it's been endorsed, meet with the nurse manager. Now, this all used to be a lot more difficult than it is now, because all of these used to be go down to the hospital, sit with somebody, meet with them in the hospital appointments. And virtually all administrators now are doing this kind of thing by Zoom. So in fact, ironically, it may be easier to get to them now than it might have been a year or two ago. And lastly, see if you can, if possible, get the care plan uploaded to electronic medical record. so that it's there when you need it. And to end on a positive note, with the publication of the ANMS guidelines, CVS is increasingly recognized in emergency departments. There's increasing interest in it, ironically because of the cannabis weed issue. There are increasingly effective medications, more than ever before. The electronic medical record may get around a lot of these organizational issues. And once something's in the electronic medical record, it's more likely to be trusted. And the existence of a plan, well, you end up getting the top of Everest a lot more easily. So I appreciate, it's been a great audience, you know, in the sense that there's been nobody rustling chairs and storming the podium, but I guess it's time for discussion now.
Thank you, Dr. Eisenmann. We like to try to keep everybody as quiet as possible. So people can ask questions in the chat box. I see one in there, but I also thought of one just with some people that I talked to. This goes a little bit past emergency care, but one thing I hear from a lot of people in the office is they went to the emergency room, they stopped the vomiting, but they didn't really get them out of the episode, and then a day or two later, they're back in the emergency room. Do you have any advice I mean, at that point, maybe those people are needing to be admitted, like how to convince an emergency doctor that's not familiar with CVS that that's the answer, or just not to send them home as quickly as they are?
Yeah, no, it's a great question. And in fact, when we had our last medical meeting and we were looking at the guideline, we realized that we didn't have the aftercare built into it. Now, in my own practice in pediatrics, 85% of the patients have something that looks a lot like migraine. And if you can control the vomiting, we send them home with medications for 1 or 2 days that are largely their migraine, continuing their migraine medication, and then something to keep them from vomiting so they can keep the migraine medication down. So there is, we didn't talk about aprepitant, which is a new medication that's available, was, as all things, introduced first for cancer patients. And my adult colleagues tell me that it is particularly effective for cyclic vomiting. But as you say, you treat the initial episode, but then we have to develop a plan for at least a couple of days for episodes. As you know, people feel unwell for some time after the emergency visit.
Thank you. Have you noticed a difference in treatment if a patient was to say that they have an abdominal migraine versus cyclic vomiting syndrome in the emergency room?
Okay, so this is where it gets, you know, I wouldn't say this is a consensus view of all the doctors. I have taken the approach, because trying to wrestle with this problem of getting recognition in the emergency department, that it's a lot easier to link it to migraine because they know how to treat migraine. So I think that's a reasonable strategy. And, you know, trial and error, see if that works better, but I agree. I'm going to elaborate on that a little bit. When doctors are doing research, they really try and slice and dice, and they try and break things down into narrow categories so that you can come to some conclusions. But sometimes those categories, in this instance, aren't all that helpful for patients. And when you're a patient trying to advocate for yourself, it may be that if the doctor looks at you blankly and says, "I've never heard of that before," then saying, "Well, pretend I have a migraine with a lot of vomiting and see what you would do."
Thank you. Let's see, the next question is, my daughter is released and advised to see her primary doc or gastro specialist, then that in itself becomes a challenge. How can we work with those doctors to see the urgency in follow-up care?
Yeah. So the way I'm going to answer that question is, again, like a lot of these issues, if you're a patient, come down to trying to get reasonable responses from doctors or the doctor's offices. And to solve it, if you keep running into the same problem, you have to think of it as a system problem. In other words, why does this keep happening? And the answer is because the emergency room doctor is responsible for a handoff to somebody. So it's very easy for them to say, see your family doctor in a week or two, or whatever it is. And I watch this happen in our emergency departments, and I know those patients don't have a family doctor. And I think the doctors just tell them that to make themselves feel better. So I think part of the planning, again, would be, what am I going to do? What do I do when I get sick? And what's our plan for once I've been sick, or my daughter's been sick, and then I go home, and work through that matrix beforehand. Because when you're sick and your daughter's feeling really terrible for a couple of days, and you're desperately trying to get through the office, that's maybe the worst time to do it. And having run a medical office, well, I won't say medical office. I'll give you the example of when you get really, really terrible service at a department store or something. You sometimes get into a discussion with them and say, did you ever try and order anything from your store? Because I'm going to tell you that this is a terrible, it's impossible. And the people who answer the phone don't know how impossible it is to get through to them. And similarly, I think the doctors don't really realize that sometimes their receptionists and nurses are actually running interference for them. So again, having that discussion when everybody's feeling okay is a far better strategy.
That's a really good point. Let's see, let me go back up here. Let's see. Have you noticed or heard of any correlation of CVS and celiac disease?
I don't think so. The thing about celiac disease is we have recognized with the blood tests that it's at least 10 times more common than we used to think. And it's about 1 out of 100 in the population. And if your parents or grandparents come from Ireland, or that neck of the woods, is even higher. So celiac disease by itself is very common. And cyclic vomiting syndrome, some people think, is 1% of the population. So there are going to be people out there who have both.
Great. Is the link to migraines the reason why you mentioned neurologists were typically better than GI doctors for adult CVS patients, or are there different reasons?
Well, there's two elements to that. All of my best friends are GIs. Like, I'm trained as a GI person. So I don't want this to be held against all my friends. But in adult GI, for the most part, people come to see you. And in adult medicine, often the question is this cancer? Is this not cancer? And so people will end up having a procedure like an endoscopy. And so many people with cyclic vomiting will have had, well, the data suggests they may have had 5, 10, 15 endoscopies. People keep doing the endoscopy, hoping that the next endoscopy is going to give them the diagnosis. The poor neurologists don't have the ability to do endoscopies. And what that means is they actually have to sit and listen to people. And they're used to dealing with people with things like migraine or problems that are not easily solved. So in general, and there are exceptions, and these are broad strokes, but in general, I say the neurologists have accepted their fate, that they actually have to sit in a chair with their butt in the chair and actually listen to somebody's story. Again, the GIs tend to be a little hyperactive and impatient. So this is not so true in pediatrics, but in adult medicine, I found that we refer our patients who are turning 18 to the neurologists, number one. Number two is we really do think that cyclic vomiting is something that is in your brain, not in your stomach. And therefore, most of the medications are medications that are directed at your brain. And the neurologists are really very comfortable with this whole range of medications.
Good answer, thank you. Doctors here, I'm assuming she means the United States, doctors here zero in on CHS, even when I've told them I didn't start smoking until after my diagnosis and have stopped smoking multiple times at their request, which make my episodes more frequent. How do I get them to stop hyperfixating on CHS and understand it's CVS?
Well, I think it's a real challenge. And I think the reason it's a challenge is the CHS or cannabis explanation is a convenient place to put the diagnosis, as opposed to dealing with something like CVS, which is kind of challenging and frustrating. And I don't know. I think, maybe CVSA should come out with a position statement on a little card that people can carry with them, that with all the seals and all the endorsement that says that, because when you're dealing with the individual doc who doesn't know too much about CVS, they're going to talk about what they know. And there's a lot, to be candid, there's an awful lot of patients out there for whom weed is not only the answer, but it's part of the problem.
Definitely. Sorry, I was just reading in the chat box. It doesn't seem like that was a question, just a statement. Yeah, one thing I was going to add from when you were talking about not bringing the whole adult treatment guidelines into the ER because the ER physicians won't read it. One thing we have done is we've actually pulled out that ER treatment example protocol and put that on a long kind of half sheet card. So if anybody that's on is looking for that, we're happy to you can just email the office and we're happy to send that to you, because we recognize, just like Dr. Issenman said, the ER is not going to read the whole, I'm not even sure how long that document is, 12, 13 pages. That is an amazing resource, but they're definitely not going to read it.
Just a comment on that, which is if you're in a hospital that is still using a metal chart or a plastic chart, the idea of making friends with the receptionist and saying, would you kindly put this on the chart for me? It's very subtle, but it's like I say, if the doctor finds it themselves as opposed to taking it from you, it's much, much more effective.
Yeah. Let's see, I have a question here. Oh, CVS hit me in my late 20s. I had 8 years of vomiting episodes. Then migraines started to overlap with the vomiting, and my CVS transitioned to full-blown migraines without vomiting for 5 years. Now I'm seeing a return to vomiting and nausea. Does CVS ever go from vomiting to migraine back to vomiting phase again? I thought it went directly from vomiting to migraine, not the other way around.
Yeah, well, people are so different. As you know, some people, things will be triggered by hormonal changes, for one thing. So as particularly women, as they go into puberty, that may start migraine. If they go out of puberty, sometimes, or they go to menopause, sometimes things may change. So I don't think you can. I don't think there's ever one answer to that question. I'm trying to think of what I was going to say about that. Oh, I was going to say, yeah, lastly, about migraine. There's a couple of, I think, things that we're looking at. One is there's an increasing range of migraine treatments available. Now, CVS doctors have felt that they didn't really work. And at our adult guideline meeting, the neurologist from Stanford, well, we had the discussion, and this is just unbelievable. we had people from all over the continent who are CVS experts. And the neurologist from Stanford said, well, do you use sumatriptan, which is the standard migraine treatment? And all the doctors said, oh, no, it doesn't work, doesn't work, doesn't work. And the neurologist said, well, how are you using it? And I'm going to demonstrate with this jump drive here. Oh, no, I've got a little vial here. Not quite, but. And the doctor said, well, we stick the thing up my nose and tip the head back and then snort it that way. And he said, well, that's the reason it doesn't work, because the receptors for the medication are actually in the front of your nose. And if you tip your nose forward and sniff it, the medication actually gets to where it's got to go. And B, it tastes terrible, and you avoid the terrible taste in the back of your throat. And this was news to the other 12 experts in the room. And when we went back and looked at the anti-migraine therapy, it actually worked about 75% of the time if you used it correctly. So that's just a little tidbit.
That's actually really interesting. That's a really good thing to know, and probably definitely something when some of these experts are GIs and they don't prescribe that very often, probably just don't know.
And again, it's in the product monograph, but no one ever, even the doctors never read the product monograph.
Yeah, for sure. Yeah, that's really interesting. Thank you for sharing that. My son, who is 22 years old, was diagnosed with CVS at 12 years old and has been taking cyproheptane since. His episodes are short-lived and manageable. Will his body become immune to this drug? And if so, what other medications do you recommend?
Yeah, so cyproheptane is basically an antihistamine, and it has this side effect, which works for some reason in CVS. One of the things we worry about is that it tends to boost appetite. And so there's a worry that the kids are going to get overweight if they're using it much into their teenage years. You do seem to get accustomed to it. In other words, there's an accommodation. And so when we use it, or people who suggest using it in cycles in order to let your body recover its sensitivity to the drug. So I guess the question is whether it's still working. Maybe he's outgrown things have gotten better, and you're giving the cyproheptane the credit. So it may be worth trying him off. Now, I'll share something. You know, when I deal with a lot of inflammatory bowel disease, and we ask patients to go on pretty intrusive medication that's pretty expensive, and we have a hell of a time talking them into it. But then when they're on it, and they've been on it for a few years, and we take those very same patients that I spent months trying to talk into taking the medication, I find I have to take months to try and talk them into stopping the medication, because people don't like to jump out of a lifeboat into the water. You know, your strategy should have a beginning, a middle, and an end.
Thank you. That's good information. I have had CVS since the age of 2. I am now 35. Is there a chance it will go away or turn into migraines?
So 90% of patients, the ones we see, if they're going to turn into migraine, turn into migraine in, as teenage years. So there's always a chance it might turn into migraine, but that's a pretty long track record. So it's really hard to say.
Let's see, I've had trouble creating a care plan since my doctor retired. I've asked neuro, who gave me many reasons why it probably won't be helpful. I've asked my GP, who said to ask neuro. I have many years of ER visits on file and diagnosis from Dr. V and Dr. Parkman. Not sure where to turn next.
Mm-hmm. That's almost a CVSA question.
I know, I was just thinking that. The person that wrote that, maybe send me an office email, cvsa@cvsaonline.org, and we can chat a little bit more about that based on where you live. would probably be, Belinda just said that. Thank you, Belinda. Let's see, I have one more up here. I was in the University of Iowa ER probably 60 times, about the same visits at local ER, and suffered at home without a ER visit twice as many times. I have been denied pain meds so many times to prove I'm not a drug seeker. Oh, sorry. The person is saying that they have not accepted the pain meds so many times to prove that they're not a drug seeker or have alcohol poisoning. Once diagnosed, I was given amitriptyline and Zofran, and sometimes visits to my doctor for shots of phenergan if during hours. How do I go about getting ER strength IV meds for home?
Right. Well, again, in terms of the ER strength, the usual med is Zofran or ondansetron as a first step. That used to be prohibitively expensive, but it's now generic and is relatively cheap and available. And I think what we're starting to see is when it was first developed, docs were reluctant to use repeat doses. But I think with experience, I think some of the physicians are more comfortable using that on a regular basis, provided that the baseline tests have been done. So that's number one strategy. And then I think you can foresee the same thing for aprepitant, which I personally have no experience with because our hospital only has a few doses and they'll only release it for cancer patients. But the adult GIs tell me that aprepitant is a game changer. And so it may be worth pursuing whether you can get that at home. And it has the advantage of being a non-narcotic, so it doesn't have the stigma attached to some of the other meds.
Thank you. Let's see. RE the link to hormones in women. My daughter has tried an IUD to eliminate her period, but has not been successful. Last week, due to COVID, she had to go to a different hospital with doctors not seen by her previously, who mentioned a possible link to endometriosis. Thoughts?
Well, my first thought is that if you think about it, I don't think an IUD is going to prevent hormone-related migraine or cyclic vomiting. The way a IUD works is that it's an irritant, and so it impairs pregnancy or impedes pregnancy. So you're going to suppress at a hormonal level, you're going to probably need either birth control pills or depot progesterone. So the good news is there may be something available that would be more helpful than what you've been doing. In terms of do IUDs cause endometriosis, that's way above my pay grade and outside of my domain of expertise. So I don't know the answer to that.
Thank you. I was just thinking back to the question of the person who asked about her CVS kind of transitioning to migraines and then back again. So this made me think of a question of my own. Is there a known percentage of people who think they have outgrown CVS, but then it seems to come back in adulthood?
Yeah. I don't know the answer to that. David Fleischer might, sort of a long-term registry, but I'm not aware that that's I've never seen anything in the literature on that note.
Yeah, and I'm sure it's hard to follow because would probably have moved from pediatric care to adult care at that point.
Mm-hmm.
Okay, I don't see any other questions, I don't think. Let me make sure I didn't miss any. Oh, I have a new one. Hold on one second. Is it normal for a person who in the past suffered attacks only once in a calendar year and have those attacks 2 to 4 years apart have 4 attacks in 1 calendar year. This has unfortunately happened to me this year. I've been admitted to the hospital on 4 separate occasions, averaging 9 days. I was finally diagnosed with CVS just this October. Oops, I just missed my thing, sorry. Sad and happy, actually, because I've been suffering from CVS for over 20 years and have even had my gallbladder taken out in 2012, only to have another attack 2 years later.
Wow. So, again, it's kind of mysterious as to why people get CVS. For the migrainers, or the people who've got a migraine pattern, there's a number of elements that can contribute to it. One is hormonal relation to periods. I find in my patient population that weather changes, much as they do in migraine. There's certain people who get it when the barometer with a barometric shift from high pressure to low pressure or low pressure to high pressure. And for those people, if it's a bad year in terms of weather, they suffer more. Similarly, I tell those people to get a barometer and to take their medication in advance of very dramatic shifts in weather. Stress, well, let me share, I won't talk about CVS and stress, but it's interesting that in our population of people with headaches and people with belly pain, that with COVID, kids that I followed for years with debilitating pain have had a really great year since March, where they are able to stay home. There's no school pressure. They get to sleep in till 10 or 11, and it's kind of slap in the face evidence that stress and anxiety really do contribute to this in some people. And you may look back on your year and ask yourself if you've had a stressful year. I know I have. So
I think that's definitely a good point. And just what you said about kids not being in school, I've absolutely noticed that in my own household with my son not having as many migraines with not having to go to school. 2 questions kind of similar, asking about if CVS can be genetic and if they can pass it on to their child.
Yeah, so the CVSA and the medical advisors have thought about this for the last 20, 25 years. And certainly for migraine is passed genetically on the mitochondria, which are little batteries in your cells, on the female gene, if you like. So if you take a history, we'll often find that there's a parent or a mom or a grandmother or an aunt, and with a pretty significant migraine history. And CVS seems to follow that pattern. So I sometimes suggest you might want to shake your family tree and see what falls out of it.
Thank you. Let's see. When I'm in an episode, I get really thirsty and want to drink a lot of water. Is it better to drink and purge or resist and keep retching often, causing more pain?
Yeah. So that's a pattern that is pretty well described. And, the doctors are just spectators to this one, if you like. And it would seem that whatever you need to do to keep yourself comfortable, if compulsive water drinking soothes your gullet, swallowing tube, then that's probably a good thing to do. Although it may be a hint that they can increase the antacids that you're taking. There's a dose, or there's an individual response to antacids, and some people are more resistant than others, and some people respond better to certain brands. So possibly there's a clue there.
I have another question. I'm on the CVS support group on Facebook, and a very common question are why some people's bouts very intense, like throwing up 3 to 5 minutes for 24 hours.
Mhm.
Oh, let's see. Sorry, I'm sorry. Okay, why do some people are so intense, throwing up a lot, but then other people throw up very few times with no pain?
Yeah, well, I don't know the answer to that. I think what we see often is if we have somebody who's got very intense symptoms, a lot of vomiting, and we find medication that's effective, like ondansetron or something else, that we can damp down the intensity of the vomiting, but they just don't feel well for the same 2 or 3 days that they used to be sick. So, there's something about the intensity of the illness that, it's expressing itself irrespective of damping down the symptoms.
And is there any knowledge of why even like say without medication, like why some people's are so much more severe than others? I don't think that's very well known in the literature currently, is it?
No, no, I think that's I just think it's a very tough question to address from a medical scientific point of view.
Yeah, no, I agree. Okay, I think that was our last question. I want to thank everyone that attended. I also want to thank Dr. Issenman for giving us your time tonight and speaking to us about the very important topic of ER care for CVS patients, because that seems to always be one of the biggest challenges that our CVS patients have. And for everybody, it'll be available eventually for recording. And yeah, I don't have much else to say. Thank you very much for spending your night with us.
Well, the one question I wondered about was, in terms of getting answers for the next group of people with this, what you hear is about failures. But it would be really great if anybody has some success stories, if you'd also kind of let Debbie know, or Belinda know, or the CVSA office, just drop a line and say, we tried this and gee, things got better. That would help. That would help a lot.
I agree. We do get those once in a while, and I do agree that is very helpful and informative for us to know what's helping people and what's not. So yes, that's a very good point.
Okay.
Yes, thank you very much. Everybody have a good night.
Thank you, everyone.